Thank you very much, Father Calin. So now that we've heard from all three of our presenters, I'd like to invite all of them back up and just give you a chance to ask your questions. So if you've ever had any questions throughout the presentation, or you have a burning question that you really want to know the answer to, you can direct it to any of our presenters, and they will give you their expert answers. So, yes.
First question, are the slides that you presented anywhere available online?
They are not currently, but I can put them up online. And the place that you'll be able to find them is archla.org/end-of-life. We have information about our Care and Prepare presentation if you'd like to have it at your parish. We also have our St. John Paul II prayer cards for the sick, elderly, and dying available at that site, and some other resources as well, including the advanced directive that you can download there.
And I just had a quick comment. As far as when you write down in your advanced directive, you know, what you want to do, be thoughtful, because if you say, I never want a breathing tube, I know when our daughter developed ARDS, they put her on a breathing tube and induced a coma to cure her. So be careful.
Now, many of the pro-life documents and magazine articles I read these days kind of gives warning about the pulse and all the advanced directives, because they lead you down a strict path that may not be appropriate for the situation you're in at the time. So they kind of say, make it as general as you can, and don't say I don't want CPR, I don't want this, because on a particular situation, on a particular day, that might be the most appropriate and practical thing to do. So the written documents, they say you really got to be careful about them. Do you have any comments on that?
I think that you're wise to say to keep them general, because the most important thing is talking to your agent or your surrogate and them understanding you. You can't possibly discuss every situation that could come up, but you know, they need to be able to make the best decision possible at that time. So
yeah, very, very well said. And I'll add. Thank you. Why don't I come closer to the rest of my colleagues? The other thing to balance these things out with is also your investment in making the right choice when you elect an agent. You see, that's why the document doesn't necessarily go immediately to your spouse or even to your children, and gives you a chance to actually select not one but two, often two agents, because those are people that could be more savvy in the medical field, comfortable, and in the process of conversation with them, they will know what is important to you as a good Catholic, and they will be able to help the rest of the team to navigate through those kind of situations. Okay? I had an example of such recently with a 90-year-old woman, Catholic from Philippines, and her son was really afraid that when we were talking about not having any more treatment options, all we were planning to do was to withdraw life support and to let her die. And because of the cultural connection, it was very important for the son to make sure that the Catholic priest will explain that to him, how that is not euthanasia, that we really simply just run out of treatment options, and the tube was just delaying the inevitable. And it was important to connect with Mary Star of the Sea, which is our local community where many of the priests are from Philippines. And that was the way to connect with somebody that he trusted culturally and from the perspective of language and everything else, and was able to let his mom be at peace and withdraw the life support so she can have an end of life in comfort.
So I wondered a little more specifics about like what the church teaching is on. For example, you had said, Father Mike, about hydration and nutrition. But does nutrition include feeding tubes and my fear is that it's happened in our family where, there's a crisis and you say, of course, do everything you can, and then that puts you on a path that you can't go back, when it's going to be obviously months and months of just a slow decline, whereas if you would have known at the time, you would have said, don't do those measures. But I'm wondering, feeding tubes, those are, you should always have feeding tubes if they can't eat themselves, or is there a point where that's acceptable not to continue that?
With these situations, I think it involves a lot of details for each situation. But what I could say in general is that we have to make sure we don't starve people to death or dehydrate someone. And so learning from our basic health tasks, we all need water to survive. We can go without food for a while, but water is critical. And that's about all I can say at that particular moment, unless we had specific situations for each situation that we were in. But we do have to make sure that people are able to survive if it's reasonable. So like I talked about my dad, he was able to eat for a long time, even though he was in the hospice bed in the family room. But there was a point that it was close to the end of his life that he couldn't eat anymore.
But did you give him a feeding tube then, or not?
No, he didn't have a feeding tube. But he wasn't. We provided what he needed. So if he wanted to eat or wanted to drink, it was provided. But there's also that part about being comfortable as well. Sometimes at the end of life, it's just not possible. You're not able to swallow or not able to take in food and hydration, which is kind of what the Father was saying a moment ago. It's not euthanasia because we're not purposely killing someone. It's just at that particular point in that person's life, it's not possible to take in. It's kind of like, maybe, I don't know if it's the best example, but it's the one that's come to mind. When we have a cold or the flu, and we should be eating, but we really don't feel like it at that particular moment, that passes over a couple days. But we're not starving anybody to death. And I think that's an important principle to keep in mind. Hydration and nutrition is important as long as it's provided to them and it doesn't cause any more discomfort to them. Remember the whole thing I said about caring for someone. We care and we provide for things as best we can.
I would like to add from my experience that, again, the world is changing, and it's changing fast. That doesn't mean that the truth is changing. And what Father is talking about, it's the effect of the truth, the fact that we cannot do anything to starve somebody. Now, the world, the clinical world changes are what we need to listen to. And here is where I will point out to the standards of care. Okay, for example, a few years back, it would have been considered to be extraordinary measures to try to put a feeding tube, because the aspects of sepsis, the aspects of the procedures will have been so overwhelming at that time that it will have been just extraordinary means of care. The truth is that in our day, that is less and less. Not in all the situations, but right now having a feeding tube is not that big of a procedure. It's done by the bedside, and this doesn't make it a pleasant procedure, but it's not as extraordinary as it used to be. And so for that reason, what I would like to kind of bring this to a conclusion that I always help our patients to understand is what's going to cause the death of a patient. If the starvation is going to cause the death, or the hydration, the lack of hydration is going to cause the death of a patient, then we should be aware of that. We shouldn't try to do that. That's not appropriate. But if the process, whatever that cancer or sepsis or whatever it is that's causing the death of a patient, will take them before the aspects of hydration and nutrition is an issue, then we don't really have to worry that much about hydration and nutrition. What Father Mike said, again, it's of great importance, comfort. And, often, for example, the aspect of hydration is very well dealt with in the hospitals today by really good care of the amount. The aspect of bringing moist lips, moist. Right. So those are things in which, by providing a good hygiene of the mouth, you can actually take a lot of these uncomfortable feelings away from the people. So just for an aspect. And overall, the rule is just this. The treatment options that we have, are they able to heal the person? Are they able to help the person? Or all they are doing is slowing down the death process? If all they are doing is just slowing down the dying process, that's what we need to talk about. Because again, if we're not able to stop that dying process, but we are just trying to kind of, extend, to which cost? And if that's all we're able to do, this procedure, this surgery, this whatever it is, if it's just going to actually maybe allow the person to live on life support for a little bit longer until their loved ones, that might be something to consider, to allow the loved ones to come and say their goodbyes. But when now it becomes, days and weeks and months, and the person is just sitting there in that kind of medical limbo where it's not fully alive, we're not allowing them to die also, then that's where we need to really consider what we're doing.
I think we had a comment in the back.
How do the doctors feel about signing the POLST for people who are not sick? Because you said that...
How do the doctors feel about signing the post for people that are not sick?
They actually won't sign it. You have to have a condition, either chronic illness or terminal illness, for them to sign that. Ethically, they won't sign it. There's no reason not to perform CPR or intubation. That's usually what the two electives on the polls. And so there's no reason on a healthy person to withhold those. For a frail person, it would crush their chest and actually, do a lot of harm. So I don't know of a physician that would sign that if there was not a terminal or chronic illness where the person was, pretty near death.
So again, the standards of training on pulse right now for the state of California is an indication for not only the physician. You know that since January it's a new law that actually allows now, besides the physician, also the nurse practitioners and the physician assistants to be the ones to document and to sign a pulse. Again, the recommendation is for all of them to sign a pulse when a person is approaching the last year of their life. This is where, again, that condition that they have has gotten worse enough to the point where we wouldn't be surprised if our loved one might not survive the next 12 months. And that's where it's appropriate. Now, of course, depends on who it is, the physician, and depends on the situations. For example, I often work very close with pediatric neurologists. And the pediatric neurologist is very inclined to sign polls because he knows how frail children are. And even though he might not be expecting that child to actually die, he feels that if they have a severe enough condition neurologically, it will be appropriate to have those kind of treatment limitations. Because, a child, because of their body mass and their frailty, they can actually get sick and diminish in a much more rapid pace than we do. And for that, he feels like it's his duty to actually address that with the parents and the guardians and have it done sooner. But for the adult, standard is a year, within a year or so of life.
We had a question right here in the middle.
I just wanted to enhance upon the feeding tube versus or fluid intake. Towards the end of life, the body actually having that can actually hasten death when, the liver kind of starts to wear down, kidney function decreases, and then you start retaining fluid, and, or it builds up around your lungs and heart, and then that becomes uncomfortable when you're coughing up or your legs are weeping. So that, that's an indicator that you may want to reconsider whether you have that tube feeding, or if you're forcing and really encouraging fluids, well, you kind of have to, that's when you have to kind of start looking, at that too, because that's uncomfortable.
And, if your insurance will allow it, and you have in your vicinity a Catholic hospital, I really encourage you to, have a relationship with a Catholic hospital, because that's where our ethics are based on the ethical religious directives of the Catholic bishops. That's at the core of who we are and what we do. And so, when your loved ones are faced with those kind of situations, then you will have the help of the entire ethics committee, simply from that perspective of addressing all those realities and looking in details. Usually an ethics committee has about 2 to 3 physicians, and if not more. And somebody will be the advocate for the patient. Somebody will be kind of the advocate for the standards of care, and like that is really a very useful conversation where families belong and are involved as well. So like that, in accordance with who the person is and what's important to them, everybody can come to a recommendation for what's appropriate as a treatment plan.
Maybe we have time for one more question.
I was just wondering, it said political and legislative end-of-life issues. I sort of expected to be explaining the new law that went into effect in June, for end-of-life, so that we could understand what this means when we end up in the hospital or wherever. Because I thought that they were encouraging hospitals
All right. So the law actually will have very little influence on the hospitals. Okay. Why? Because actually the core of the law is not allowing any healthcare practitioner to participate. Okay. So the patient has to do it on his own. Nobody can even, give him the medication or give her the medications. They have to go through this three-pronged system in which they have to prove that they know what they are doing, they know what they're asking for, and they are truly of freedom to actually take the poison on their own. And so for that, nobody in the hospital can be of any assistance. Even like a hospice cannot really get involved. The nurses will not be able to do that. If a patient decides to do that, they have to be able to do it on their own. If anybody else does it, it's a crime. Okay? Is that helpful to kind of put a little bit of understanding on the law?
Kind of, but I have also been to the Vita Institute where they explain that there's ways to go around all of that.
Well, I'm sure if there's no documentation and behind closed doors, that would be a situation. But what I'm trying to share with you is that not only our Catholic hospital, because of our, again, Catholic beliefs and the ethical religious directives, will not participate, but all the other hospitals in the county that I know, all of them choose not to participate because it's such a nightmare for anybody in the healthcare system to really be involved with that. So for that, if a patient, for example, wants to come to the hospital and they'll bring the medication with them, that medication will be checked out and they will not have access to it. And then the medication will be returned to them and they can take it home. Okay? But, would it be possible that, for example, in the hospital, let's just talk about the situation, right? Would it be possible that in the hospital, you have now a patient who is suffering of terminal cancer, terminal illness of some sort, and then you have the family and they bring the medication which was already dispensed at home, They bring it, and then the patient decides one day that it's just too tough of a day, and he or she decides to have it. And at the time, again, maybe the member of the family will help them. But guess what? The entire cold glue team will show up, and they will revitalize the patient. So can you imagine what a horrible situation when you just poison yourself, and now you have doctors, nurses pounding on your chest, doing electric shocks. I mean, talking about punishment and hell. It starts here. So, for that reason, the hospitals are very clear. We cannot participate. We do not want to participate. We cannot have anything to do with this. And so, for that reason, I'm not aware, at least within our county, of any of the hospitals even entertaining the thought. Doesn't matter if they are community hospitals or any other religious affiliations as well.
Just to add to that just a little bit, just if you're interested beyond this meeting in terms of legislative and political information regarding assisted suicide and any ongoing efforts right now, there's not anything happening since assisted suicide passed. There were some court cases that were brought forth and a few other things that were trying to overturn it. There was a referendum that was trying to overturn it as well, and none of those efforts was successful. So right now, the Catholic bishops have decided to focus on promoting palliative care, hospice care, good end-of-life care, and trainings like this one. And this is actually something that's going on around the country, is trying to encourage people to understand what good end-of-life care looks like, especially among our Catholic parishes, so that people would not even consider assisted suicide. And if you're interested in any legislative efforts that may come up, those cards that we sent around, if you sign up for our emails, you'll be alerted if there's anything that's going on in the legislature about that. Yes, that. Right there. So thank you all so much for coming out. I really appreciate it. If you have other questions, I'm sure you could probably ask our wonderful folks here.